Hello students, the topic for today's lecture is aggressive periodontitis. Myself, Dr. Kunal Sethi, will be explaining you details about this topic today. So let us start. Aggressive periodontitis, as the name suggests, it is a disease which affects systemically healthy individuals under the age of 30 years. It describes three diseases that were once classified as early onset periodontitis. So previously it was also called as localized juvenile periodontitis and many other names, prepubertal periodontitis, but currently the name which is accepted and which is used regularly is aggressive periodontitis. What are the distinguishing features? So how will you differentiate aggressive periodontitis from chronic periodontitis or other types of periodontal disease? These are the distinguishing features. The age of onset. This disease starts relatively early in life, around 25 to 30 years. So it is seen in young adults and not in older adults like chronic periodontitis. Also, it has a rapid rate of progression. That means the bone destruction, the features of periodontitis start appearing very quickly in this disease. There is apparent lack of local factors. This is a very important feature. As compared to chronic periodontitis, in aggressive periodontitis, you will not find plaque and calculus in large amounts in the patient's mouth. You will only find minimum amount of plaque and calculus, and that is how you will differentiate or diagnose this disease from other diseases. Also, the nature and composition of subgingival microflora. So in this disease, mainly gram-negative and anaerobic organisms are involved. So that is also one of the distinguishing features of aggressive periodontitis from chronic periodontitis. There are alterations in host immune response. So the patient's immune response is not normal in patients suffering from aggressive periodontitis. There will be some or the other immunological defect which will be there in case of aggressive periodontitis, because of which the body reacts very aggressively. There will be a lot of destruction of bone in a very short period of time. Also, a characteristic feature is familial aggregation of diseased individuals. So generally it has genetic component, aggressive periodontitis. So parents who are affected by aggressive periodontitis, there are high chances that their children will be affected by this. So this is a distinguishing feature. Now let us see two types of aggressive periodontitis. First is localized aggressive periodontitis, and the second one is generalized aggressive periodontitis. So as the name suggests, localized aggressive periodontitis means that only a few teeth are involved, and generalized aggressive periodontitis means the entire mouth, all the teeth, maxillary and mandibular, are involved. So in 1923, it was Gottlieb who first described this disease. He gave some characteristics and called it as diffuse atrophy of alveolar bone. So this is the historical aspect of aggressive periodontitis. The characteristics which he noted at that time were loss of collagen fibers in periodontal ligament, replacement of collagen fibers by loose connective tissue, extensive bone resorption, widening periodontal ligament space, and uninvolved gingiva. So the gingiva is not much affected. What is affected is the periodontal ligament, the bone, and there is extensive bone resorption. So this was the description given way back in 1923 by Gottlieb. So he differentiated this disease from chronic periodontitis. It was also called as deep cementopathia in 1928. The characteristics noted then were inhibition of continuous cementum formation, which was necessary for maintenance of the periodontal ligament. So this disease was thought to be having cemental defect. So it was thought that Mainly the cementum is defective in this sort of disease. Disease of eruption where cementum caused a foreign body reaction. So this was the pathophysiology given for aggressive periodontitis. And body tried to exfoliate the tooth by pocket formation and bone loss. So it was thought that this is some sort of autoimmune reaction where body is trying to get rid of the teeth, and that was one of the explanation given for causing of this deep cementopathia. Then as time passed by, different names of aggressive periodontitis started coming in. In 1938, it was called as periodontosis marginalis progressiva, where the typical incisor molar relationship was seen. That means the first molar and the central incisor were first involved. And then later on, as the disease was spreading, the other teeth started getting involved. Till 1966, the name periodontosis was used instead of periodontitis, which is currently used. It was thought to be a degenerative non-inflammatory process related to trauma from occlusion. There was a world workshop in 1966, and there a lot of points were discussed, and one of the point discussed was this disease of aggressive periodontitis. So there the conclusion was concept of degenerative disease was not substantiated, and this was removed from periodontal nomenclature. So this periodontosis, which was thought to be a degenerative disease and not an infectious disease, that concept was not substantiated, so it was not accepted, and the degenerative nature of this disease was removed. In 1967, Chaput and colleagues gave the first name as juvenile periodontitis. Juvenile means seen in youngsters, and because it was so commonly seen in young adults, it was called as juvenile periodontitis, and chronic periodontitis was called as adult periodontitis. In 1969, Butler noticed the localized nature of this disease, and therefore he called it as localized juvenile periodontitis. In 1971, Bayer defined this disease as the disease of periodontium occurring in an otherwise healthy individual, which was characterized by rapid loss of alveolar bone, about more than one permanent tooth, which was not commensurate with the amount of local irritants. So this was very interesting finding. He noticed very early on that although the amount of plaque and calculus was very minimum, but compared to that, the bone loss and the damage which was caused was very severe. So little amount of plaque and calculus, local factors will cause lot of bone loss, lot of damage. So there was no commensuration which was noticed. Then in 1989, in the World Workshop of Clinical Periodontics, there was a lot of discussion, brainstorming on this aggressive periodontitis. And there it was thought to be a subset of early onset periodontitis. So localized juvenile periodontitis, the name was accepted across all the researchers of the world, and it was thought to be a subset of early onset periodontitis. Then 10 years later, in the International Workshop in Periodontics, the name was again accepted as localized aggressive periodontitis. So from juvenile periodontitis, the name was changed to aggressive periodontitis, because sometimes it was seen in older adults also, like younger adults. So the name juvenile was removed and aggressive periodontitis was the more appropriate name which was given. Let us see the clinical characteristics of localized aggressive periodontitis. The age of onset is around puberty, that is 13 to 15 years, this disease starts. There is rapid rate of disease progression. The rate of bone loss is 3 to 4 times faster than that of chronic periodontitis. So this is also a differentiating feature. where in this disease there is very fast bone loss. The localized nature, that is first molar incisor presentation, is seen. So typically this disease will have bone loss in the first molar and the central incisor. They are the first teeth to be involved. And when it is localized in nature, then only these two teeth will be affected, or the neighboring teeth, but other teeth are relatively not affected. The interproximal attachment loss on at least two permanent teeth is seen, one of which is first molar, involving no more than two teeth other than first molar and incisor. So maybe first molar and second molar is also involved sometimes, and sometimes first molar and central and lateral incisor is involved. So no more than two teeth other than these two teeth are involved in localized aggressive periodontitis. If more than these teeth are involved, then it is called as generalized aggressive periodontitis. Lack of clinical inflammation in spite of deep periodontal pockets. So not only is the plaque and calculus less in the patient's mouth, but the signs of inflammation are also very less. Minimal plaque deposits inconsistent with periodontal destruction. So very less plaque seen, which is also not consistent with the amount of bone loss. Contains elevated levels of periodontal pathogens. So the main bacteria, main etiology which is causing this disease is Actinobacillus actinomycetum comitan. This is the microorganism which causes this disease, and Porphyromonas gingivalis. So AA is the causative organism which has a lot of properties to evade the host immune response, and because of which it causes aggressive periodontitis. So in the patient's mouth, calculus formation is very rarely seen. In aggressive periodontitis, what is seen is mainly plaque, which is there, and that too, it is very less in amount. Some cases progress to affect other teeth, which is called as generalized aggressive periodontitis. And in some cases, the disease stops on its own. It is self-arresting. So in some patients, the disease will go from localized to generalized, whereas in other patients with good immune response, the localized will be, the nature of the disease will be stopped. It will not progress to generalized aggressive periodontitis. So other clinical features which you will see in the patient's mouth are distolabial migration of incisors, midline diastema formation, increased mobility of first molars, sensitivity of denuded roots to thermal and tactile stimuli, dull, deep radiating pain during mastication, food impaction, and periodontal abscess formation. So these are also clinical features which will help you to differentiate this localized aggressive periodontitis from other types of periodontal diseases. Let us see the radiographical features now. On an X-ray, this localized aggressive periodontitis will typically show vertical or angular bone loss around first molar and incisor in young healthy individuals. The bone loss pattern is described as arc-shaped or saucer-shaped bone loss, starting from distal surface of second premolar to mesial surface of second molar. So this is how the bone loss is present: arc-shaped or C-shaped bone loss from second premolar to mesial surface of second molar. Let us see the prevalence and distribution. It is seen in below 1% of population in geographically diverse patients. So in very few patients, you will find this disease. In Europe, it was seen that 0.2 to 0.1% of the population is affected, whereas in US, it was slightly higher, 0.53%. Black males are more at risk than black females. White females are more at risk than white males. So females are more at risk in the white population, and in the black population, males are more at risk. The predilection is female in younger age group and male in older age group. So that is how, as the age increases, the predilection of both the sexes changes, females in younger and males in older. And in middle age group, it is equally affected between males and females. So what are the reasons for limitation of periodontal destruction? That is why the localized aggressive periodontitis does not progress to generalized aggressive periodontitis in some patients. The reasons which are given, which have been proved by research, so some of them are still under research, but the probable causes are mentioned here. First is the evasion of host defense by the causative microorganism, which is AA. Production of leukocyte chemotaxis inhibiting factor, endotoxins, leukotoxins, collagenase. So the host defense, initially, they evade this chemical inhibitors which are secreted by AA. Stimulated immune mechanism is one of the second reasons which has been given, which occurs after initial attack. So it is thought that body fights back this infection by producing antibodies after the initial attack. Production of opsonic antibodies, phagocytosis of invading microorganisms, and neutralizing of leukotoxic activity. So after the initial attack, it is thought that the body learns to fight this infection, and therefore it does not spread to generalized aggressive periodontitis. Colonizing of bacteria antagonists to AA. So it is thought that some other bacteria also, they start playing a role in the patient's mouth, and they are antagonistic or opposite to AA, and therefore they prevent further colonization. Loss of leukotoxin producing capability. So this is another reason that the bacteria loses its ability to produce the leukotoxin, which is causing destruction. And the reason for this is unknown. Defects in cementum production. So it is thought that the cementum is defective in the initial tooth formation of the first molar and the central incisor. These are the first few teeth to develop, and therefore they have this defective cementum, and therefore they cause localized aggressive periodontitis. Then let us see the other variety of this disease, which is generalized aggressive periodontitis. The clinical features are, it affects patients under the age of 30 years, but older ones may also be affected. Therefore, the name juvenile periodontitis was removed. It affects at least 3 permanent teeth other than the first molar and incisors. Interproximal attachment loss is seen, and the destruction which occurs in the patient's mouth is episodic in nature. That is, continuous bone loss is not seen. It happens in specific phases, episodes. Poor antibody response to pathogens. So the response of the patient is very poor. The antibody response is very poor, and therefore the disease progresses from localized to a generalized aggressive periodontitis. Small amounts of plaque with elevated level of Actinobacillus actinomycetum comitans. So the causative microorganism will have very high level of this bacteria, which produces leukotoxin, endotoxin, collagenase, and all these will cause severe bone destruction in the patient's mouth. So two types of responses are seen. One is the active phase and second is the passive phase. So as previously explained, the disease is in episodes, and in episodes there are two types of phases, active phase and passive phase. In active phase, severe acutely inflamed, proliferating and fiery red gingiva with spontaneous bleeding is seen, where there is a lot of inflammation seen in the patient's mouth, suppuration and loss of attachment, and mobility is also seen in the patient's mouth. In passive phase, the gingiva appears to be normal. It is pink in color. There is no inflammation. There is lack of bleeding and suppuration. But if clinically examination is done, then deep pockets will be seen. Systemic involvement is also seen in some patients in the form of weight loss, depression, and malaise. Now let us see the radiographic findings of aggressive periodontitis. They range from slight to moderate localized bone loss to severe generalized bone loss. So it can be slight, moderate, or severe in nature. Comparative X-rays taken at different times can illustrate the rapid rate of progression. So you have to keep the patient of this disease under long-term follow-up, and only then you can come to know the pattern of bone loss, whether it is slow or whether it is rapid bone loss occurring. 25 to 60% of bone loss occurs in 9 weeks. So this is a very fast-paced disease and patient has to be treated aggressively. There was a very important study which was done in Sri Lanka to find out the prevalence and distribution of aggressive periodontitis. In Sri Lanka, it was seen that in 8% of individuals, there was prevalence of bone loss with 0.1 to 1 mm of bone loss seen in 1 year. And in US, it was seen that the prevalence of aggressive periodontitis was 0.13%, more in 14 to 17-year age group, and there was more predilection for black males. The risk factors for aggressive periodontitis are as follows. Microbiologic risk factor, this is the most important risk factor, wherein the microorganism AA is the principal pathogen. It is found in 90% of the cases. The sites of disease progression show elevated levels of Actinobacillus, Actinomycetium comitans. Elevated serum antibody titers to AA are seen in the patient. Reduction of AA is seen after treatment given to aggressive periodontitis patients. It produces various virulence factors which causes the disease. Other pathogens which are involved are P. gingivalis, P. intermedia, and C. rectus. These are the other three microorganisms. Another important risk factor is the immunologic risk factor. It is seen that the human leukocyte antigen is the marker for aggressive periodontitis, and HLA-8 and HLA-B15 are associated with the generalized aggressive periodontitis. It is also seen that functional defects of neutrophils and monocytes is seen in aggressive periodontitis patients. This affects the chemotaxis and phagocytosis of periodontal diseased patients. So because the neutrophils cannot do phagocytosis and cannot perform chemotaxis, the immunity of the patient is reduced. This may be genetic or bacterial induced. Hyperresponse of monocytes is also thought to cause increased bone loss and connective tissue destruction. So this is another theory which explains rapid bone destruction and bone loss, that is hyperresponse of the monocytes which causes aggressive periodontitis. Autoimmunity may be a cause of host antibodies to collagen, DNA, and IgG. Another risk factor is the genetic risk factor. Familial pattern of bone loss implicates genetic factors, but no gene has been identified. Major gene responsible is transmitted through autosomal dominant mode of inheritance in Afro-American population. So till now, a specific gene has not been identified, but it is seen that this disease has a typical familial pattern. Immunologic defects, especially neutrophil abnormalities, may be inherited. Antibody response to AA is under genetic control and may be race dependent. Not all patients have genetic defects. The environmental risk factors are amount and duration of smoking may affect extent and severity of destruction. So if the patient is a smoker, then definitely there are more chances of the disease spreading from localized to generalized in nature. Smoking may not have serious impact on patients with localized aggressive periodontitis. So it is seen that the effect of smoking will be mainly seen in generalized aggressive periodontitis patients. So thank you all for a patient hearing. Myself, Dr. Kunal Sethi from Department of Periodontics, MGV KBH Dental College and Hospital, Nasik. Thank you.